For the millions of people living with endometriosis, the pain can be this relentless, confusing puzzle, right? Even when treatments seem to target all the visible signs of the disease, that pain often just sticks around. So what if the problem isn't just in the pelvis? What if it's actually in how the brain itself is processing pain? Today, we're going to dive into some really cutting-edge science that's starting to uncover a hidden cause.
Okay, so first, let's just set the stage and really look at the core problem that so many people are facing. It's this frustrating cycle of treatment and then pain recurrence that has left both patients and doctors just searching for answers. And this is the central question, isn't it? You go through all the hormonal therapies, you have the surgery to remove the lesions, you expect relief. But for so many, the pain either comes right back, or maybe it never really left in the first place. So, why? What is going on? And this number, honestly, is just startling. Get this. The research shows that over 40% of patients experience persistent or recurrent pain within just 5 years of standard treatment. We're not talking about a small minority here. This is a huge challenge that tells us we are absolutely missing a major piece of the puzzle.
So, this leads us to a really fascinating and frankly game-changing idea. What if the issue isn't just about the physical endometriosis lesions? What if the problem is that the entire nervous system has fundamentally changed how it interprets and even generates pain signals?
To really get our heads around that, we need a quick primer. Because, as it turns out, not all pain is created equal. The International Association for the Study of Pain actually breaks it down into 3 key categories, and understanding them is crucial. Okay, so first you have nociceptive pain. This is the type of pain we're all pretty familiar with, right? Think of a cut, or a burn, or a sprained ankle. For endometriosis, this is the pain that's coming directly from the inflammation and irritation caused by the lesions themselves. And for a long time, this was thought to be the only kind of pain involved. Then you've got neuropathic pain. Now, this happens when the endometriosis lesions actually grow into or wrap around nerves, causing direct damage. It's pain that's coming from the nerves themselves being injured. And that brings us to the crucial third category. And this one is a total paradigm shift. Nociplastic pain. This is pain that comes from an altered pain system. The original injury might be gone, there's no ongoing nerve damage, but the central nervous system itself, it's been rewired to produce pain all on its own.
So, to put it simply, with nociceptive pain, the problem's at the site of the injury. With neuropathic, the problem's with the nerves. But with nociplastic pain, the problem isn't in the pelvis or the nerves anymore. It's in the central processing unit, the brain and the spinal cord. It's become hypersensitive.
Okay, so how does that even happen? Well, the main mechanism behind nociplastic pain actually has a name. It's called Central Sensitization, and this is where the science gets really cool.
So the official definition calls it an amplification of neural signaling. But what does that really mean? Well, basically, the volume knob on your body's pain system gets turned up to 11, and then it gets stuck there. Your nervous system becomes hyper-responsive, putting you in this constant state of high alert.
This analogy just illustrates it perfectly. Imagine you've got this faulty car alarm. At first, it only goes off when there's a real threat, a break-in. But over time, it gets so sensitive that a single leaf falling on the windshield or a gust of wind can set it blaring. That is exactly what happens to the nervous system in central sensitization. Normal, everyday, non-painful signals get misinterpreted as major threats. And this hypersensitivity, it shows up in some very real ways. It's not just about pelvic pain anymore. We're talking about widespread pain that goes way beyond the pelvis. Pain from just a light touch, that's a condition called allodynia. You might see increased sensitivity to sounds, or light, or even smells. And then there's the DIB fatigue, the sleep problems, and that really frustrating brain fog. Any of that sound familiar? These are all major clinical clues. So if this pain is being generated by the nervous system itself, how in the world do you find it? How can a doctor actually identify it in a patient? Well, this is a huge focus of current research. Now, it's really important to know that there isn't one simple blood test or scan for nociplastic pain. Well, not yet anyway. But the research we're looking at today shows that scientists are making these huge strides in developing real tools to detect it. And just look at this for a second. This chart shows you the incredible, rigorous process behind the research we're talking about. The scientists started with nearly 400 studies, and they systematically narrowed them all down to find the 30 most relevant ones, the ones that held the best clues. That's a massive effort just to find the best methods.
So what did they find?
Well, they found a whole toolkit, really, with 3 main approaches. First, there are patient questionnaires that really dig into specific symptoms. Second, there are semi-objective tests that can actually measure things like pressure pain thresholds. And third, there are hands-on clinical exams like looking for myofascial trigger points.
And one tool that comes up again and again is called the Central Sensitization Inventory, or the CSI. It's a questionnaire, and the research has actually validated a specific cutoff score for endometriosis. If you score 40 or higher, it's a really strong indicator that central sensitization is at play.
So why does that score matter so much? Here's the crucial point. Studies show that patients who score above 40 are the very same ones who are more likely to still have significant pain even after a successful surgery. This makes the CSI an unbelievably valuable tool to screen patients beforehand, manage expectations, and plan for the right kind of treatment.
And this is where it all leads. Identifying the right type of pain isn't just some academic exercise. It completely changes the roadmap for treatment. It offers a whole new kind of hope.
So the new approach is actually super logical and personalized. Step 1, you identify the dominant type of pain. Is it nociceptive, neuropathic, nociplastic, or maybe a mix of all 3? Then, step 2, you tailor the treatment plan to that specific pain signature.
And that is the fundamental shift. If the problem is actually in the central nervous system, then treatments that only focus on removing lesions in the pelvis just aren't going to be enough. You have to treat the brain's pain amplification system directly.
And that opens up this whole new, exciting toolkit. We're talking about things like pain neuroscience education, just teaching patients about how pain works, therapies like CBT, specialized physiotherapy, mindfulness and meditation, even dietary changes and medications that work to quiet down that overactive nervous system. It's a true team approach for a really complex problem.
So we end right where we began, but now with a whole new perspective. After decades of focusing only on the physical lesions, this research suggests a profound truth, that to truly heal the pain of endometriosis, we might need to look beyond the pelvis and into the intricate wiring of the brain itself. And that shift in focus, well, it might just be the key to finally unlocking lasting relief for millions.